You're now listening to the Engage the Rockies podcast, your go-to podcast for local and state issues concerning Colorado.
Hello, Rockies. This is Sarah Jane Maroney, your host. And today we are joined by Travis Bockenstead and Candace Klinger, speaking about direct primary care. Travis Bockenstead is the president and chief experience officer of Pinnacle Advanced Primary Care, where he leads the company's strategic growth while ensuring exceptional experiences for patients and clients. He's the co-founder of Pinnacle and has helped to grow the subscription-based direct primary care practice into one of the fastest growing DPC providers in the country, now serving over 250 employers through 3 clinics in South Denver and Colorado Springs. Candace Klinger is the office manager of Alpenglow and began in May of 2018. After working in a local school district, she started college as a nursing major, but changed along the way to business. Alpenglow allows her to apply both sets of knowledge to her professional career. Outside of work, Candace can be found trying new restaurants, traveling, and spending time with her family. Welcome, Candace.
Thank you for having me.
We appreciate you being here. So today we're talking DPC. What does that even mean?
DPC is direct primary care. It is a smaller version of concierge care. I think a lot of people are familiar with concierge care, where you pay a couple $1,000s a year to have a doctor kind of at your beck and call, come to where you are and help treat you. Direct primary care is still having a doctor and being part of practice, but we have regular business hours, although you can still be seen on the weekends if need be. And we have some great communication methods, and you can still be talked to on those as well and treated if needed. But most of what we do is Monday through Friday, 8 to 5 with your doctor.
And so that's, I'm seeing a doctor for 15 minutes and in and out of there.
We don't have those kind of constraints. That's what's so nice, because we're not answering to anyone but you. So you are paying us to help champion your care, where we put you in the driver's seat of your care. So we can make your appointment 15 minutes. And that for sure is something that we do sometimes when we're following up with someone. Maybe we just need you to come in to check your blood pressure and you're out the door. Usually, though, our appointments are 30 minutes and you sit down with Dr. Rogers and you talk about either a new thing going on, or you get a physical, or you follow up on something. He could even decide that you're going to spend a whole hour there, because that's what he needs to take good care of you. Because we're really only answering to you. You are in the driver's seat for your health care. And I think there's a lot of people out there that don't feel that way, that feel like they're just not in control over how they're treated, what the steps are to getting treated, and they feel kind of powerless. And we like to put that power back. And one of the ways we do that is by the relationship that you build with the doctor, for sure, but also with the office staff, because we also come to know you when you call, when you need to get in, and what is going on. It's that personal piece that's missing that most people look for. And they really want to develop that relationship with their provider.
And so how do payments work? Obviously, with insurance, you have your insurance card, et cetera. How does that work with a DPC?
With a DPC, we are membership-based. So you pay a monthly fee, kind of like a gym membership. Our rates are $95 or $105 a month. It depends on your age. It's very easy, over or under 40 years old for adults. And whether you come or not, you're going to pay that monthly fee, because that is the fee to have the care from Dr. Rogers when you need it. It works out really well for people. It pairs very well with people who have commercial insurance. And we will make sure that if you have a greater need and you have to go on for additional care, you need a specialist or you need to go to the hospital, that we are sending you somewhere that's going to work within that network. Some of our members who don't have commercial insurance have medical cost sharing plans, which are growing in popularity to kind of rival the commercial insurance industry. And we will also try to champion the best places to use those plans here in the area, which physical therapists that is, which hospital network that is. And then we have a small segment that have no other care but us, because that is the best they can do. We also work our hardest to champion for those patients as well.
So in that case, so let's say someone didn't have any other insurance, they signed up with a plan to pay, and they were older, so they were paying they're paying $105 per month, right? So roughly, just a little over $1,200 a year, and they fall down the stairs and break their arm. What do they do then?
They are going to come to us. We're going to get them some cash price x-rays. We can even set their break depending on what it looks like here. Obviously, if they could see their bone, we would have to send them right on to a hospital. We would have no choice there. But if it wasn't that complicated, we would be able to set that here. We would have some braces and things here. We would also be able to show them what they might need. Or if they do have to see an orthopedic specialist, we have a couple that will take cash patients. We'll get them in right away. Unfortunately, the cost for that is what the cost is. But we have some working relationships with people like that in town, and a lot of them are open to payment plans and things for people who don't have any sort of insurance.
And how does that work with medicines? My daughter has asthma and often needs to buy inhalers and things like that.
So we are able to offer low cost, usually older generic medications right here through our office that get dispensed by Dr. Rogers. The new ones, if there's a commercial for it, we probably do not have it. That advertising is a lot of money. There's a lot of science behind that. And without going on a huge tangent about big pharma, it's just not usually affordable to someone who does not have commercial insurance. So the pharmacy that we keep in-house is a little more like older, tried and true blood pressure, cholesterol, headache, and then a lot of antibiotics. So if you were to come in with like the worst sinus infection, you could just leave with the medicine. You then don't have to make another stop to go somewhere and pick up another medicine because you already don't feel good. So that is nice. We're pretty competitive. Sometimes we're $1 or $2 more than if we set your prescription to a local pharmacy. But for most of our patients, they really don't mind. So we're $15 for a 3-month supply instead of $14 with the Walmarts and Targets and those pharmacies. So most of our patients tend to prefer to fill when they can with us. Some of the asthma medications that you were referring to can be a little tricky, but some of those inhalers, again, are older and they're not as expensive. We also do try to utilize GoodRx whenever we can for someone who isn't going to have any other coverage, and we will flat out tell you, you want to go to Walmart for this. They're going to be cheaper than us. We are doing medications directly at our cost. We are not making anything on them. The same is actually true for blood work. If you were to come in and get your blood drawn, we would tell you exactly what we think Quest is going to charge for that and draw your blood and then bill you for that when we get that bill in from Quest. And again, we don't make any money on that. The only way our direct primary care makes any sort of money is on those monthly dues. And if either of those services stop being a benefit, if we would have to consider raising that membership for the blood work or the prescriptions, we just would not do them because that is not what we're trying to do. We try to be very transparent and take all that guesswork out that people just never know when they go to the doctors. And that was one of the things that actually got me into direct primary care to begin with, was some of my own personal experiences taking my own children to the doctor. When they were little, they would get sick. I would wait a couple days. I had a great support system, but then I worked for the school district, so I had to get a substitute to come in so I could go to the doctor. Then I had to make sure I called at 8 o'clock so I could get in. Then I'd get there, and I either was an overreactive parent who brought in a kid that just had a cold, or this was the sickest child they'd ever seen who needed a chest x-ray, and somehow, even after paying a $50 copay, this was a $400 or $500 visit. And how did I not bring this sick child sooner? I never left feeling like I did the right thing. Like, way to go, Mom. I always left feeling like I didn't do the right thing, that I didn't do the things I was supposed to do. And that really upset me. And that is one of the reasons that I ended up kind of coming to direct primary care to begin with, so that I could bring my kiddo in and say things like, I know you don't know my son like I do, but I assure you, when he chooses to lay on the couch and it's perfectly nice outside and he's not running around, it's a problem.
Wonderful. Well, so final question here. Is there a way to game the system? Let's say I don't have to go to the doctor, but maybe once a year, could I just join for that particular month and then quit?
Unfortunately, we really prefer that you do not do that. Although we have had a few that do that. Dr. Rogers kind of calls that ping-ponging. So we do have a little clause in our membership agreement that if you were to join and then cancel and then rejoin, that he will charge up to 4 months for the difference, because that's not good care. And we really want to give you good care. We do not want to just see you on those 3 days a year and you don't feel good, because that's not great for anybody. That's
Sure,
not
but
what we're trying to do.
$1,200
build
for a year is a good deal. It really
For a
is.
lot of people, it is. And a lot of people will end up with insurance or they have other things later and they don't necessarily cancel. They really like the model and the care that they get when they come.
Awesome. Well, Candace, thank you very much. This has been a great overview, and it does seem like a brilliant option for a lot of people.
Absolutely. AlpenglowFamilyMedicine.com.
Travis, thank you so much for being here.
Glad to be here.
So we know what DPC is now. How is Pinnacle Advanced Primary Care different? It's a DPC, yes?
Yeah, absolutely. So we're really lucky in the state of Colorado to actually be top 2 in the nation for DPC practices. So the DPC movement is alive and well here in our state, which I think makes us really special. In the Colorado Springs market alone, I think we're nearing like 20 different DPC practices in our market. Yeah. So I'm really happy to see the movement grow. Within our marketplace, we have 2 types of DPCs. We have direct primary care practices that are single location and primarily serve retail customers. And that is an awesome place for us to be because people need healthcare. The place where Pinnacle lives in is we are primarily employer-based. So 70% of our members come from companies of all sizes in town. So we take solopreneurs, self-employed individuals, like realtors are a good example, or maybe you own your own independent pest management company or something like that. So we do work with solopreneurs. We have 250 businesses total that we work with, ranging from 1 employee all the way up to 125 plus employees, not counting their dependents. So we serve employers of all sizes here in the community. And I believe that's where we can really start to make an impact in healthcare reform, is empowering business owners, because business owners are the biggest purchasers of healthcare.
So how would that work if a company, pest control company that has 30 employees decides to go with you guys? Do you have enough capacity to pick up more? And how many offices? What kind of office hours? What does that look like?
Yeah. Because we serve employers, we actually have 3 clinics spanning from South Denver all the way to Cheyenne Mountain. So basically, if you're in Colorado Springs, we bookend town with 1 at Cheyenne Mountain and 1 at Briargate Medical Center. And then our clinic serving South Denver is primarily, of course, serving, I would say, like Castle Rock North would be that market. We hire based on how full we get the providers panel. So about 50%, when they hit 50% of their panel load, we are then out to market hiring another physician. That way there's never any disruption in care or access or anything like that. And we actually have 8 physicians waiting to work for us. So we don't have a talent pipeline issue. More and more primary care providers are wanting to get back to true family medicine, what they got into the business to do. And I'm sure your other guests have talked about what that feeling is like for a provider to not have to see 30 patients a day, but instead 6 to 10 usually. We have not had a problem scaling the practice at all. In terms of hours, Monday through Friday, 8 to 5 are the normal clinic hours. But through direct primary care, you do get unlimited telehealth and digital access. So we can serve our customers after hours, weekends, and holidays where they can reach their actual primary care physician. What's different in the DPC space is we don't outsource our telehealth to like Teladoc. Most DPCs do their telehealth in-house, which is really key because you want that continuity of care. So we want to make sure the physician you're seeing in person is the physician you're seeing virtually. Now, DPC docs have a life too. So oftentimes they'll just pass that care off to one of the colleagues in the clinic. We do work with clients also, like our school districts. We have some rural school districts. So we'll actually bring the clinic to them, and we make it more convenient for the company, the teachers and staff to get care with us.
Wow, that's amazing. And how would that work if an employer already has some type of insurance? Or let's say they go with you, but then what do you do with the emergencies where you do need the ER?
I think it's important first to make a distinction between health insurance and health care. I think the consumer gets confused that their health insurance company is a health care company, and they're not. They are a billing and payment system that funnels money between multiple middlemen, and that is the reason why our cost of care is so high. On the direct primary care side, as your listeners are finding out, we're completely carved out of the insurance market completely. We are standalone. Think of us like your dental or vision. You kind of have that carved out of your plan. Now, where the magic of DPC happens is when we talk about cost containment. So there are insurance arrangements called self-funded health insurance plans. This is easiest way to break it down is where the employer takes all those monies paid by their employees and puts them in a pot. And let's say there's $1 million sitting there to cover claims. Well, if your employees are going to the ER and urgent care for UTIs, sinus infections, things that could be taken care of in the primary care office, you're draining those funds quite a bit for everyday health and wellness needs. What insurance is really designed for is to protect somebody from going into bankruptcy if they have a major medical event. So we say to these companies, hey, why don't we make primary care the foundation of your health plan? Because a good DPC can take care of 90% of your everyday health and wellness needs. And then we'll just use your plan for big things that happen. There are organizations saving $1 to $2 million year one by partnering a DPC clinic with a major medical plan. And so that's kind of where some magic can happen. Now, you don't need to have a self-funded health plan to partner with the DPC. You can have many different plan arrangements, and we do work with all kinds of health plans. But really the magic is, can we introduce employees back to what real primary care, real preventive medicine is, and reduce the need on the big expensive part of our healthcare system?
So when you say 90%, we're obviously not talking about cancers or bones sticking out of your body, but we are talking about, I don't know, blood work, setting bones, things like this that aren't acute?
I would say like sprains, things like that. If there's not a bone sticking out, we can do an initial evaluation. I always tell people if it's your life, your limb, or your eyesight, meaning your life's in danger, you've severed a limb, you poked out your eye, you need to call 911 immediately and go to the ER. If it's not a life-threatening situation where you are not in horrible discomfort, then more than likely your primary care physician can take care of that. When we look at chronic illness, maybe someone is borderline type 2 diabetes, right? And they're getting a 7-minute doctor visit and they're just getting put on another medication. The chances of that person lowering their A1C level and not being a type 2 diabetic is slim to none, right? They don't have a support system. So we can come in and we might meet with this patient every week or every other week till we get them to where we need them to be. Chronic illness, you can imagine having, our average visit time is 40 minutes long per patient. So you can imagine having 40 minutes with your doctor to work through a chronic illness that you have or something like that. So I personally believe that a good primary care doctor can do most of everything you need. And being available in the DPC space means that after hours and on weekends, we're providing peace of mind for that member to know, hey, you're not dying. You're okay. Here's what you have. I'm going to send you a script to the nearest pharmacy, or let's see you first thing on Monday to get you in.
Wonderful. And how did you come to that? I mean, obviously you are interested in this because you're a co-founder of Pinnacle. Is that right?
Yeah, I have actually worked in the DPC space for 7 years. My why is a $26,000 surprise medical bill. And this was 7 years ago before we had some of the Surprise Medical Bill Act. We have some things in place now to try to prevent those, but that did not take place. There was a loophole in my insurance plan where they didn't cover any of it. And it sent me down a rabbit hole of why. And I was so angry because no one could give me a cost. I started looking up the true cost of some of the things on my bill, and they had jacked up the price like 1,000% on stuff. So I did a simple Google search. I didn't want a physician hooked to big insurance or big healthcare. And I Googled doctors who don't accept insurance. And 7 years ago, I came upon this. Before that, I worked in the media industry, was the world that I worked in. So now I get to take my passion for storytelling and marketing and be a full-time evangelist for the direct primary care movement.
That's amazing. And so how many doctors do you have currently at Pinnacle?
So we have 3 doctors, a PA, a full medical assistant staff to support all of them. And then we have reception and a member onboarding team. And because we do work with so many employers, we have a full onboarding team that engages those members and gets them in the door when they join the practice. So, and then we add those physicians, like I said, based on how their panel is growing, and it has worked really, really well for us. I want to get more physicians into this healthcare model. And I don't care if you're working for me or starting your own practice, we want to see more folks get into it. Unfortunately, only about 20% of family practices are owned by the family doctors anymore. And so we believe in diversifying our healthcare economy, and it's never a good idea to have all our eggs in one basket, as we found out over the last 5 years. So I want to see us diversify our primary care system and bring it back local where it should be.
So a little bit of a controversial question here. In Colorado, I'm aware that if you are a Medicaid patient, you can't come and use your services. Is that correct?
There are actually two laws that we need to fix. So yes, if you are on Medicaid, it is illegal for you to go to a DPC practice and use your own money. You can't spend a buck with us. The problem is that folks on Medicaid cannot get any access. So as a taxpayer, we are paying for them to go to ER and urgent care for their everyday health and wellness. Now, I'm a DPC purist. I don't want insurance money. I don't want government kickbacks. I'm completely free market independent. So when I talk about expanding DPC to Medicaid, I don't want those dollars. What I do want is for a patient to electively decide where do they want to get their care. Now, if there's something outside of our practice, we could send them through the Medicaid system to get those major medical needs met. But I guarantee you we would lower the money spent by the taxpayer on this particular program. The other thing that we need to fix is our HSA laws. If you have an HSA account, you legally, per tax code, cannot use your HSA money for DPC membership fees. Now, you can use it for labs and medications and procedures in office, but you cannot put your membership fee on the HSA card. It's a gray area that people are in. I would say talk to your tax accountant, but I don't see any reason why, if those are your hard-earned dollars that you are tucking away for medical expenses, that you should have the freedom to spend them at the practice you would like. I truly believe it is the system that wants to keep the money in the system, or a very antiquated tax code that favors a healthcare system that is anything but affordable. So those are two things we're working on. I would ask people to demand Congress allows access to HSAs, and here at the state level, that Medicaid recipients get the option to go to our practice if they would like.
Wonderful. Well, I have learned so much. If an employer were interested in contacting you guys, where would they go?
So I would first start your Google search with direct primary care employers, and that should pop up some DPCs in your area that are working with employers. You can go to pinnacleapc.com to find more information about what we do. And if you Google DPC Mapper, it will come up with a DPC map from across the country where you can find a direct primary care clinic in your backyard. I support everybody in town. I don't care if you're a solopreneur DPC or a multi-location like us. Every person needs to take an active role in their healthcare. And if we are tired of the system, then let's start investing in free market models that are doing the right thing.
Wonderful. Thank you so much, Travis. Really appreciate your time.
Thank you.
Thank you for listening to the Engage the Rockies podcast, your go-to podcast for local and state issues concerning Colorado.